They're ready, sir. They're ready.
I think we'll start on time. We'll have 4 cases today, so we'll start on time.
Yes, sir. We'll start.
Okay. Good morning. A warm welcome to all my colleagues. And I'm indeed happy today to have 3 of my erstwhile colleagues with me. Professor Balasubramaniam, who will be chairing this session, and Dr. Vijayan and Dr. Aruselvan from Coimbatore will be sharing their experiences and presenting cases by their residents in medicine. It's the first time that residents in medicine are presenting. So we will be happy to have them on board. And I now hand over the proceedings to Professor Balasubramaniam, Professor of Neurology at Madras Medical College, Institute of Neurology. And I request him to kindly take over the proceedings and conduct the meeting. Thank you, Professor Bala. Please take over.
Sir. Thank you, sir. Good morning, one and all. I sincerely thank Professor B. Nadarajan, sir, for inviting me to chair this critical neurology forum. The 21st webinar we are conducting. The moderators of this session are Dr. K. Vijayan, who needs no introduction. Is a senior consultant neurologist from Royal Specialty Hospital, Coimbatore, and our dear friend Dr. Aruselvan, who is also consultant neurologist, Royal Specialty Hospital, Coimbatore. Without wasting time, we have 4 cases. We shall proceed to, over to the moderators for the case presentation and for the discussion. Over to Vijay, sir.
Good morning, sir. Good morning, Professor Vijayan. Good morning, Balasubramaniam, sir.
Yes.
Good morning, everybody. Now, we have our medicine postgraduates. We don't have a DM program. We have a medicine program. So we have medicine postgraduates. Final year, sir, you can ask any questions. There are exam going. So we'll start off with the first case, sir. It's a case of quadriparesis. Over to the presenters.
Yes, yes.
Please don't log in at same place to Zoom laptop. Please don't log in to laptop at same place.
Okay. Good morning, sir. Hello.
Excuse me, please don't log in to laptop at same place. Please change the room. Change the room. 2 people together don't log in.
Hello. But the mute button. Then mute video stop பண்ணிடுவா. அது கிளிக் பண்ணுங்க mute.
Not a video. Good morning, sirs, respected sirs, and my dear colleagues. Today, I will present the topic mistrust the obvious, a case of acute cardiomegaly.
Are we audible, sir?
The voice is breaking. Perhaps she'll have to come closer to the mic, I think. Voice is breaking up at times.
Hello.
Sir, am I audible now?
Yes.
Say got it.
So presentation is not.
It came just now.
Screen share.
Go to your presentation. Go to the presentation. Yeah, is it there?
No.
How did it come on my screen?
Yeah, because I was sharing from home.
Do one thing, stop mail and share from this. Share from this only, stop mail.
Okay.
Sir, 1 minute, sir, we'll share it.
Yeah, please take your time. Please,
Just 1 minute, sir.
please.
Stop there. Just stop, put it, switch it on.
Leave.
No, leave me. Leave me. Okay, that's okay then. We can start. Yours is on?
Yes.
You go ahead. What? You have to share.
Yes, sharing.
The phone number out. Sir. You may not be nervous now. Relax.
Yeah, feel free. Feel free. Be relaxed. You can't get such a receptive audience as such here.
You be relaxed. You be relaxed. No, you work. Just start. You start your presentation. Say good morning and start.
Sir,
No, open it. Okay, you then present from there. Okay, not coming. Yeah, don't do the thing. Got it. Yeah. Open. That's open. Yeah. That open. Bring it in.
Morning, sir.
Morning, Arul.
Well,
Welcome.
Apologies, కొంచెం late అయింది.
Not at all. You are welcome anytime.
Thank you, sir. Thank you.
Thank you. Alina is about to present a case.
Morning, Arun sir. Sir, you have to unmute. You have to unmute your.
Right.
Morning, sir. Morning,
Morning.
sir. Welcome, sir.
Good morning, sir.
just connecting Suraj. Good morning, sir. Am I audible now?
Yes, please.
are you able to see the screen, sir?
You will have to share. Right.
Okay, sir. Good morning, sir. Respected sirs and my dear colleagues, I'm going to present the topic Mistrust the Obvious, a case of acute quadriparesis. So the case, Vinay, it's a 29-year-old woman. She was admitted with complaints of both upper limb and lower limb weakness with breathing difficulty and multiple episodes of loose stools and vomiting. She had been in her usual state of health until 3 days before this admission, when she had multiple episodes of loose stools and vomiting, followed by bilateral upper and lower limb weakness, following which she was taken to the emergency of a local hospital and evaluated there. Certain routine blood investigations were done. It is showed like HB was 10.2, her total count was 2100, creat was 0.8, sodium 140, potassium was low, it was 3, bicarb was 12, still low, and total bilirubin was 0.28. So she was managed with IV fluids, IV antibiotics. Later, she was initiated on inotropic supports there and intubated and ventilated since she was not protecting her airway. She was transferred to this hospital for further management. On the day of admission, the patient was evaluated at the emergency of this hospital before transferring to the ICU. Her temperature was 100.4, her blood pressure was 170, heart rate was 78 beats per minute, her respiratory rate was 32 beats per minute, and her saturation was 100% on ventilator support. So she was awake and obeying simple commands and tolerating the ET. The cranial nerve examination was within normal limits, except that she was unable to shrug her shoulders. Palatal and gag reflex could not be tested as she was intubated. The power was grade 2 in both upper limbs, grade 1 in both lower limbs with preserved and just elicitable reflexes, and bilateral plantar reflex was flexor. Then other cutaneous reflexes, that abdominal reflex could not be tested since she was paralyzed. And she could not
Stay safe. Don't keep on rocking.
her anal tone was reduced. Sensory examination, she was able to feel light touch, pinprick, and temperature normally in all dermatomes. Her cardiovascular system examination, S1, S2 was heard. There was no murmur. Respiratory system, chest was clear. Air entry was equal bilaterally. She had no history of fever, abdominal pain, lower urinary tract symptoms. Her patient had a history of rheumatoid arthritis. It was diagnosed 1 year back. In view of persistent joint pain and stiffness, she was taking native medications for past 20 days. And her blood investigations done then showed a RA factor which was positive. CRP was high, it was 44.5, and the BP recorded in that week was 90/60. In the emergency department, an ABG with electrolytes was done. So this is the ABG, which was done at 1:55 p.m. on 23rd of September. As you can see, the pH is 7.070. It is showing severe acidemia. And PO2 is 147 on ventilatory support with FiO2 40 and PEEP8. ECO2 is 24.3 with a very low bicarb, 6.9. So it shows severe metabolic acidosis. Her sodium is 147 with potassium of 1.05 and chloride of 118. So there is severe hypokalemia with hypochloremia, and her lactate is 0.81. So,
Shall we stop here, sir?
Oh, yes, by all means, why not? We can ask some of the Sherlock Holmes over here to proceed. Since we want to, since already you stated, mistrust the obvious, and you want somebody to play the Sherlock Holmes, we can
Yes,
have
sir.
some volunteers.
Yes, sir.
We can start off with the obvious and then go on to what is not obvious.
Yes, sir. Yes,
Anybody
sir.
wants to start off with the obvious? Bala, you can guide through. Okay, I'll start off the obvious being hypokalemic related weakness. The next obvious one will be infection related, post-infective, acute inflammatory demyelinating neuropathy, polyneuropathy. And the third obvious would be indigenous treatment related polyneuropathy. These would be my obvious reasons.
Yes, sir.
As Vijayan has already said, probably these are none of these three. So others are welcome to give their suggestions.
We also
Bala, you
thought,
please take over.
we also thought of these three possibilities only, sir, initially.
Yeah. Bala can invite comments from others. Professor Bala?
Sir, my first possibility is as you suggested, sir, my acute flaccid quadriparesis due to hypokalemia. The patient has got acidosis, so and the background rheumatoid arthritis. So in this situation,
Your voice is breaking, Bala. Bala, your voice is breaking. Can you come closer to the mic, please?
Yes, sir. Now, okay. Am I audible, sir, now?
Yeah,
Sir, now-
better. Better,
Yes, sir,
Bala.
now, yes, sir.
Go ahead.
It's a hypokalemic periodic paralysis with acidosis. So probably we have to, and with the rheumatoid arthritis, what I would suggest is roll out a renal cause, whether it is renal tubular acidosis related hypokalemic paralysis. Second possibility is since the patient is having rheumatoid arthritis with an acute flaccid quadriparesis, I would also suggest an acute radiculoneuropathy. And these are the two possibilities which I would think. And any other comments or any other possibilities from the other discussion, other members is invited, sir. Any other possibilities?
The calcium is also very low. Could we explain the hyperkalemic periodic? The calcium is very low. It's only 1.4. Is that correct, Vijay? 1.4.
So that's ionized calcium, sir.
Oh, right.
Ionized calcium, just below the lower limit of 1.2. 1.2 is the normal. It's 1.14. sir.
Ionized calcium. That's okay. Let's accept it.
And the precipitating factor has been vomiting and loose stools for past 3 days the patient has been having.
Yes.
So that could be one of the stimulating factor for this disturbances. And with the background acidosis, so I'd like to rule out a kidney disease background with rheumatoid arthritis also in the background, and patient also taking native medicine intake. So possible renal disease with hypokalemic periodic paralysis, one of the syndromes. Anything, sir? Anything? Anybody else?
Dr.
Any
Ishwar
comments
Das,
from the audience?
So what was the treatment for rheumatoid arthritis she was taking?
So the treatment actually, we have all what is available is from the histories and native medications, and we could not find the content of the native medications. So that is all that is available to us.
She was on steroids for a long time.
No, sir, she was not on steroids, sir. She was diagnosed 1 year back, but past 20 days, she gives a history of native medications and it was not available. What content was there was not available.
The gross metabolic acidosis. So, what did you clinically think about it, Bhai?
Yes.
She came with acidotic bleeding, or what was she in respiratory failure when she came along with?
She was intubated elsewhere, sir. She was intubated elsewhere and she came here. Her PCO2 was normal.
Yes, sir. It was 20. It was 24.
In fact, she was washing out.
Oh.
I think she has a combination of bulbar palsy and polyradiculoneuropathy related to the low potassium. As Bala
sir.
and Ian sir correctly said, we need to exclude a renal tubular acidosis. We have
Yes,
to think
sir.
secondary
Yes,
cause
sir,
of
exactly. We also thought exactly on those lines.
renal tubular acidosis, whether it's
Yes, sir, type.
Yes, sir.
Type 2.
But only thing which was not fitting in was this acid-base balance. And two, when they told us that she had respiratory failure and hence she was hypokalemia rarely causes respiratory paralysis and cranial nerve palsies. So we were thinking there is something else also hidden along with hypokalemia. So we proceeded with the.
So for further investigations, so can I move on, sir? the next slide.
did you feel that the rheumatoid arthritis was active in her or just present?
Not so. So just her rheumatoid factor was positive, sir, and her CRP was not not significantly high, sir. It was around 44, and she had like persistent joint pain, but there was no swelling as such. And
Anti-CCP, madam, anti-CCP.
the anti-CCP it was not available, so that report was not available. We had done it here at our hospital. It was high, sir.
One comment.
Sorry, sir. Sir, proceed, sir.
No, go ahead. One comment regarding what Dr. Azuselvan said. Yes, we don't very much see respiratory involvement with hypokalemic paralysis, but I think there was a paper from SWIMS, Tirupati, where they had reported about 7 patients having going in for respiratory embarrassment in around 22 patients. I think 1/3. That was the only, series which I had read. from SWIMS where respiratory embarrassment was mentioned in hypokalemic paralysis.
That's
Yes,
what
sir.
I wanted to say, sir. That's what I
It
wanted to
can
say.
occur.
Very rare, but it is certain reports are there with respiratory paralysis also, sir.
Yeah, it can occur, but it is very rare. That's
Rare,
what
sir.
kept us probing further.
Alima, she had any Sika syndrome also coexistent with rheumatoid arthritis because the renal tubular acidosis are quite common in Sjogren's syndrome.
Yes, sir, that
But
was a possible.
dry mouth, dry eyes. Did you get any history like this?
So there was no, we had asked a history of dry eyes and whether there was a reduced lacrimation, but she did not give, her attenders did not give us history of
Okay.
Sjogren's, sir.
Okay. Okay.
So this above ABG shows a severe metabolic acidosis with hypokalemia. The compensation, it is not, it's uncompensated. Actually, the PCO2 expected compensation is around 70 to 20, but here it is 24.
Anita, there is one, I don't know who you are, Anita or Alina.
Ali,
Your name pops up as Anita, but there is a question in the chat box. It asks regarding the thyroid status.
So
The
that
question is regarding thyroid status.
yes, sir. We are coming to the lab data, sir. Actually, the
Okay,
thyroid
okay.
function tests. Oh, okay. Sir.
Okay, you proceed along your
Okay,
way
sir.
of presentation.
Okay, sir. So it's a high anion gap metabolic acidosis, sir. Here the anion gap is around 21, and since it's a mixed acid base disturbance, we have to calculate the delta gap. It was less than 1. So the delta
fit in with RTA.
It didn't fit in with the RTA. So when it is less than 1, we are suspecting a HAGMA with a NAGMA, which is a normal anion gap metabolic acidosis. So here the lab data comes up. So its HB was around 11.5, total count 5,500, a platelet of 209,000 with MCV is 85. Her ESR was 47, her procal was negative, RA factor still high, 129. Her sodium was 147 with serum potassium of 1.1 and chloride of 118 and bicarb of 8.2. And her creatinine was 1.3, borderline high. Her urine complete showed acetone was absent, albumin was trace, and RBC was 15 to 20. Her thyroid function test was within normal limits. Her urine spot potassium was 5.5, which is normal lab value here is 3.6 to 5.1, so it is slightly on the higher side, with a TTKG of 3. So here comes the causes of HAGMA. So the 4 main causes of high anion gap metabolic acidosis is mainly one is lactic acidosis, ketoacidosis, ingestions, and severe kidney dysfunction. So in this patient, we are again probing what was the cause of shock in this patient, what resulted in the metabolic acidosis. So one possibility we had in mind is since she was having a lower BP, she was hypotensive in the previous hospital and was resuscitated with fluids. Probably her lactic acid levels was normal in our IBG. So maybe it had got corrected with the IV fluids which we had administered. Then the next possibility is her HAGMA had developed because of her normal anion gap metabolic acidosis. Unlikely to be a ketoacidosis in this patient since she is not having a history of diabetes mellitus, and starvation is unlikely and alcohol associated. Ingestions also is unlikely in this patient because we do not have a history of methanol or ethylene glycol, aspirin, toluene ingestions. Then a severe kidney dysfunction. She was maintaining a urine output of 40 to 50 ml per hour and her creatinine was borderline high, which is due to the systemic hypoperfusion and her shock, which was present at the time of admission. Then next we are coming to the causes of NAGMA. So one is GI losses, which is there, the history is there in this patient, multiple episodes of vomiting and loose stools was there. Then type 2 proximal RTA, post-treatment of the ketoacidosis, carbonic anhydrase inhibitors, urethral diversions, moderate renal dysfunction, type 1 distal, that is hypokalemic RTA, hyperkalemic type 4 RTA, and voltage defects. So this is a ABG nomogram, which is showing the compensation for the metabolic acidosis. I have marked with a blue star that the pH is around 7.07 in this patient. She's having metabolic acidosis. Her bicarb level was 6.97. So it's showing respiratory compensation is enough, sufficient in this nomogram. But when we come back again to the history, we'll know it is not compensated. So in further course in the hospital, she was resuscitated with fluids, started on inotropic supports. Simultaneously, we were correcting her potassium and soda bicarbonate was ongoing. And she maintained a urine output of 40 to 50 ml per hour. Since we were evaluating her for septic shock, so we sent her the routine cultures, blood, urine, and endotracheal tube cultures were sent. She was started on injection meropenem and injection teicoplanin. Her repeat ABG after 6 hours, the pH was still on the lower side, but it was improving. It was 7.267. Her PO2 was 129, still on ventilator support. PCO2 23.8, slightly it is compensating. Then sodium 155 with hyperchloremia, and potassium, which was 1.5, and bicarb, which was improving 10.6, and lactate was creeping up. It was like 0.8 before, now it's 1.1. Her anion gap was still high, it is 22, and the delta gap was less than 1. So we still corrected her soda bicarbonate correction was ongoing, potassium correction was ongoing. So when we reassessed the patient, she was conscious, obeying with her limb power, which was improving. Then since her shock was refractory to inotropic supports, and we had sent a random cortisol since she was on native medication, and there was a suspicion whether there was steroid content, which was normal. And when we initiated her on steroid infusion, her shock had improved. So we continued to, but the patient, she continued to require ventilator support, and she was not able to tolerate the CPAP trials. So we did a chest X-ray. It showed clear lung fields. And we had done cardiac evaluation. ECG didn't show any signs of hypokalemia. It just showed sinus rhythm with low voltage complexes, and the echo had a normal LV function. So now to reassess. So this is a patient, Mrs. S. She's a 29-year-old female, a woman with a history of rheumatoid arthritis on recent native medication. Her shock, which we can account for her hypovolemia, which is due to her GI losses, or possible adrenal insufficiency since it responded to steroid infusion, and her high anion gap metabolic acidosis with a normal anion gap metabolic acidosis, and her quadriparesis, which is a subacute in onset and progressive. And we are considering here the possibilities of a hypokalemic periodic paralysis, a myasthenia gravis, possibility of myasthenia gravis, or a hypokalemia, which is secondary to autoimmune disorders, like probably Sjogren's. Then she had another issue, which was hypoxia and weaning issues. Still, we are suspecting myasthenia gravis or fluid overload, since we had resuscitated her with a lot of fluids in hospital.
Shall we stop here, sir? Shall we stop here, sir?
Yes, sir, as you want. Professor Bala decides what is to be done. There's a question also as to whether there is any history of laxatives or diuretics.
No, sir. There's
No history of laxatives or diuretics, sir. She had excessive vomiting and diarrhea for the past 3 days, that's all. Her power had improved, her muscle power had improved, but we were not able to wean her off the ventilator. The respiratory paralysis remained.
Professor Bala, you can proceed further as you deem fit.
The renal, what about the cause for the steroid, improvement of steroids? The patient having adrenal insufficiency. Could it be any renal syndromes causing hypokalemia and acidosis? We have some...
we had considered renal syndrome, sir, but the delta anion gap was like, it was contradicting our...
The high anion gap acidosis was contradicting with the renal tubular acidosis, which is usually a normal anion gap acidosis. But when we further reviewed the acid-base balance, we found out that she also had a normal anion gap metabolic acidosis. And when we corrected the acidosis, the normal anion gap metabolic acidosis, hypercholoremic acidosis still remained. So we thought of Sjogren's syndrome, we had asked for investigations, and our SSA was strongly positive. SSA was strongly positive. It was a renal tubular acidosis, yes. We had in spite of the renal tubular acidosis, in spite of correcting hypokalemia, and in spite of the power improving in the limbs, her respiratory, we were unable to wean her off the ventilator. That was the issue there.
Vijayan, can I take a long shot?
Yes, sir, please.
You have mentioned a diagnostic test was sent.
Yes,
Yes,
sir.
sir. Yes, sir.
Was it anything to do with Clostridium botulinum?
No, sir.
Because there is neuromuscular involvement and she had loose stools. So
Yes, sir. Yes, sir. We thought about that, sir, but it's not that, sir.
Okay, thank you. Somebody wants to know the ECG changes pre and post potassium.
Pre and post ECG changes.
So it was a normal sinus rhythm with a low voltage complexes.
So before the...
So prior to administration, it was a normal sinus rhythm, sir. Post treatment also we had a normal sinus rhythm, so we did not have any hyperkalemic changes.
Would it be a combination of both?
Bala, you're not audible. Combination of what? Both? What?
Though it's very unlikely, sir. Whether a combination of, immunological radical neuropathy plus muscle.
Yes, sir, we thought of that also, sir. Whether that could be a
because they were
combination
not
of
able to wean out from a ventilator.
wean off the ventilator. That was the only point here, sir. We were not able to wean her off the ventilator. We thought of fluid overload. We did a chest X-ray. We did a ultrasound which showed pleural effusions. We tapped the pleural effusion. Yeah. Shall we go ahead, sir, with the next?
Not able to wean off for how many days, Vijay?
So for past actually following admission, sir, 48 to 72 hours, we are not able to wean her off from the ventilators.
Power improved.
So
but
so following power improvement, 2 days, we were not able to wean her off from the ventilators.
That's a short period only. Okay, we could wait. Right, go ahead.
Any
Sir,
antibodies planned, sir? Any antibodies planned?
Yes.
Yes, sir.
Yes, sir. Yes, sir.
Antibodies.
Yes, sir.
Yes, sir.
Pertaining
Yes, sir.
to both nerve and what I
Yeah.
would suggest is what I would think is it is since the patient is having an autoimmune disease.
Yes, sir.
Propensity for autoimmunity. Patient is suspected Sjogren's.
Yes, sir.
Yes, sir.
Connective tissue disorder.
Yes, sir.
Yes.
The combination of both neurogenic and myogenic problem in this patient. That could be the cause for difficulty in weaning off from the ventilator in spite of partial improvement. So I would suggest some antibodies, both pertaining to nerve and muscle, including neuromuscular junction. That's what my thought process goes.
Yes.
What sort of antibodies, Bala?
Sir, to rule out an atypical radicular neuropathy, sir.
Agreed. But what antibodies should
Would
we like to
GM1,
look for?
anti-GM1 and anti-GQ1B and
Okay.
one neuromuscular junction antibodies, sir. Acetylcholine receptor and for
That
neuromuscular
becomes
junction.
myasthenia.
Yes, sir. That is what, sir. That is a common. I feel it's a
Then we could
common.
do I don't know whether, was it possible to do an RNS?
Sir, we didn't do, sir. It was not possible. She was in the ICU and she was in shock. So we didn't do an RNS at that stage. Sir. We
Okay,
did not
okay.
do.
Okay. Or, okay, short of that, the so-called, which of course, instead of tensilon, pyridostigmine.
We didn't start it initially, sir.
She initially she had diarrhea, sir. So we didn't start her on pyridostigmine, but
Or
of course.
prostigmine. Prostigmine test, IV prostigmine test, no.
No, sir, we didn't do that.
Sir.
Okay,
But
okay,
I think we are there, sir.
okay.
So can I go ahead, sir?
Please. Bala,
Yes. Please
can she
proceed.
go ahead?
Yes, please proceed.
Okay, sir. In view of persistent hypoxia, so we repeated a chest X-ray which showed bilateral pleural effusion. Her cultures had come, it was sterile, and we de-escalated her antibiotics. She was afebrile and her limb power was improving. Then we sent a diagnostic test. Then 48 hours later, we had repeated her ABG. Her pH had improved 7.4. Her PO2 was 210, PCO2 of 21. Bicarb also improved 12.7. Her potassium was slowly improving 1.57. Still, it was showing a hyperchloremic metabolic acidosis, but now it became a pure metabolic acidosis because her delta gap was equal to 1. So we continued her soda bicarb infusions and her potassium corrections.
Why
the
the pleural effusion?
So that is
Why-
so one possibility was a fluid overload. Then since we are suspecting autoimmune condition, like we were suspecting Sjogren's, even though the history was unlikely and we are unable to wean her off. So then that's the possible cause.
Okay, a systemic autoimmune problem.
Yes, sir. Yes, sir.
Okay.
So then the diagnostic test results were received. Her ANA was 3+ granular nucleoplasm pattern. And ENA showed SSA triple positive SSA, SSB, and Rho52, and her acetylcholine receptor antibody was also positive. So then her further course in the hospital. So our suspicions of autoimmune etiology were confirmed. Steroid infusions were stopped, and she was initiated on high-dose IV methylprednisolone. Her shock had improved, and we had done an ultrasound screening of the abdomen, which showed mild ascites. So a polycirrhosis, likely autoimmune etiology, was confirmed. So we did a diagnostic tap and the results are as follows. And it was also a sterile tap, and it was showing a transudative pattern. So then she was following administration of high dose steroids. She was gradually weaned from the ventilator and her inotropic supports were stopped. And we gave her a dose of injection rituximab, 500 mg on 27th. That is almost a week, almost 4 to 5 days following admission. Her potassium had normalized and we extubated her on 48 hours following administration of rituximab. During her hospital stay, she had a gradual decline in platelets with no bleeding manifestations. So a possibility of heparin-induced thrombotic thrombocytopenia was kept, and we had withheld a heparin, following which her platelets had improved. So we had started her on pyridostigmine and switched her to oral steroids, a Metrol of 16 mg OD. Then she was shifted, Mrs. S, we had shifted her to ward. She was mobilized with support, started on oral feeds, and her repeat blood counts showed an improving platelet counts, and she was discharged home with a tapering dose of steroids and planned to start mycophenolate mofetil on follow-up. So few words about hypokalemic periodic paralysis. Hypokalemic periodic paralysis is most common of the periodic paralysis, but it's still quite rare with a prevalence of 1 in 1 lakh population. It may be familial with autosomal dominant inheritance or may be acquired in patients with thyrotoxicosis. A mutation in the gene that codes for alpha-1 subunit of the dihydropyridine sensitive calcium channel in skeletal muscle is the most common genetic abnormality. Sodium channel disorders. Mutation in the skeletal muscle sodium channel, SCN4A, is also responsible for the syndrome in other families. Coming to clinical features, attacks occur suddenly with generalized weakness. Consciousness is preserved. Bulbar and respiratory muscles are only rarely affected, if at all. They begin in late childhood or in teenage years. They affect proximal more than distal muscles and the legs more than the arms, with hyporeflexia or areflexia is typical. The treatment. The important caveats of acute treatment include the following. The presence of hypokalemia must be confirmed prior to therapy, since if we administer potassium, it may worsen hyperkalemic periodic paralysis. The administration of potassium during an acute episode may lead to post-treatment hyperkalemia as potassium moves back out of the cell. The treatment should therefore be administered incrementally, like every 30 minutes oral correction we have to give. So the post-treatment potassium levels should be monitored in 24 hours. Potassium should not be administered in solutions containing dextrose, as patients have an exaggerated insulin response to carbohydrate loads. Cardiac monitoring is recommended during treatment and post-treatment monitoring. Carbonic anhydrase inhibitors appear to be effective in reducing attacks of periodic paralysis. Acetazolamide 250 mg BD is commonly reported to be effective in attacks. The subset of patients who experience mild fluctuating weaknesses between attacks reportedly find acetazolamide treatment helpful. A potassium-sparing diuretic, either spironolactone or triamterene, can be effective as monotherapy or a supplement to acetazolamide. So coming to Sjogren's, Sjogren's syndrome is a chronic multi-system autoimmune disorder. It is characterized by lacrimal and salivary gland inflammation with resultant dryness of the eyes and mouth and occasional glandular enlargement. There are two forms. One is primary form. It is not associated with other autoimmune rheumatic diseases. And the secondary form, it's often associated with rheumatoid arthritis, SLE, or a systemic sclerosis, like in this case. A classification criteria. So we have a scoring system. In this there's a labial salivary gland with a focal lymphocytic sialadenitis and a focus score of more than or equal to 1 foci per 4 millimeter square, which will give a score of 3. If there's RO anti-Rho or SSA positive, it gives a score of 3. Then ocular staining score using either Rose Bengal or Lissaman stain, we get a score of 1. Then Schirmer's test less than or equal to 5 millimeter at least in one eye, which gives a score of 1. And unstimulated whole saliva flow rate less than or equal to 0.1 ml per minute, which gives a score of 1. Then the prevalence of extraglandular manifestations in primary Sjogren's. Sorry.
Not audible, not clear.
Hello.
Go
Go on,
ahead.
go on.
So the
First move forward.
Okay, so this is in short the treatment guidelines for Sjogren's syndrome with glandular and extraglandular manifestations. In this particular patient, she is having extraglandular manifestations like renal tubular acidosis, where we are replacing bicarbonate. Then dry eyes, dry mouth, and parotid gland enlargement, which are glandular manifestations. We are just giving symptomatic treatment for that. Coming to myasthenia, it is a neuromuscular junction disorder characterized by weakness and fatigability of skeletal muscle. The underlying defect is a decrease in the number of available acetylcholine receptors at NMJs due to antibody-mediated or 200 in 1 lakh. And affected individuals, it affects individuals in all groups, but in women in
Malcolm.
20s and 30s and men in 50s and 60s.
Malcolm.
Hello, sir.
Go ahead.
Okay, treatment now available for myasthenia is highly effective, although a special cure has remained elusive. Coming to clinical features, women are more frequently affected. The cardinal features are weakness and fatigability. The weakness increases towards the end of the day. The course of myasthenia is often variable. Okay, the distribution of muscle weakness has a characteristic pattern. The cranial muscles, lids, and extraocular muscles are typically involved early in the disease. Diplopia and ptosis are common initial symptoms. So coming to the diagnosis of myasthenia, it basically history itself will give us a lot. Then physical examination, then lab testing, where we test the acetylcholine receptor antibodies, the NCS study, the repetitive nerve stimulation study, the hydrophonium chloride test. Then coming to management, which is this algorithm which helps us in managing myasthenia.
The reason this case was presented, sir, was initially when they told me it's hypokalemic periodic paralysis. Then when we went and assessed the patient, then we found out the severe metabolic acidosis. Then what we initially told that hypokalemia seldom causes respiratory paralysis. So I said there is something other than hypokalemia. We have to look for that. Then when we found out, when we saw the acid-base balance, we were again dumbstruck. We saw a high anion gap metabolic acidosis where we were expecting a normal anion gap metabolic acidosis. The clue was the hyperchloremia here. So then we looked into further details, and then we found out that definitely there was both a high anion gap and a low normal anion gap metabolic acidosis mixed here. Then we again found out that the respiratory compensation was also not adequate. That was also lurking in our mind behind. So we said that let's send for the other. Since she had a diagnosis of rheumatoid arthritis already, we said let's send her anyway for all the SSA, SSB, and which turned out to be strongly positive in this patient. So our suspicions proved right that she had Sjogren syndrome. But once the power improved in the lower limb, still we were not able to wean her off the ventilator. Commonly, we thought that it is fluid overload and pleural effusion. Then we just asked for an ultrasound. We also had mild ascites. So we thought it was again a polycerasitis, part of autoimmune disorder. And then finally only we thought, why not think of myasthenia also in this patient, because she's not we are not able to wean her off the ventilator since there is an associated connective tissue disorder already. So then we sent for acetylcholine receptor antibodies, and which was strongly positive again, very strongly positive. And then that's how the puzzle was solved.
Jane, may I know the titer, please? Acetylcholine receptor antibody titer.
Titer, I forgot, sir.
It was 31.
31, yeah, 31 nanomoles per liter.
This is really, really highly positive, yes.
So it's a coexistent disorder.
Sir, I think
and
my one doubt, sir,
Sjogren's.
whether it is a Sjogren's with myasthenic crisis precipitated by hypokalemia, or is it the Sjogren's with myasthenia with hypokalemia, periodic paralysis?
The only thing against the primary periodic paralysis was usually they don't present with the first onset of attack after the age of 25. She was 29. That's okay, but still, usually they don't present with the first attack after the age of 25, usually.
So it is basically a Sjogren's with myasthenia.
The Sjogren's with myasthenia, yes, sir. Basically, Sjogren's with myasthenia. She had a diarrhea, vomiting, precipitated possibly by native medication, and that's why she also had the severe high anion gap metabolic acidosis also initially when we saw her.
But what is peculiar is both are concurrent, both are subacute onset, with
Yes,
no
sir.
evidence of previous involvement of either Sjogren or myasthenia.
Yes,
Except
sir.
for that, she was a she had rheumatoid.
Yes, sir. Except for that rheumatoid, there was nothing, no other clue to suggest a concomitant autoimmune disorder.
Excellent. Yeah.
It's
Very unique and peculiar. Yeah.
So just because ACHR is positive, can we take this as myasthenia gravis? Any other feature to say it's myasthenia, thymus, any other?
No,
finding?
sir. She did not have any she did not have a thymoma,
Any
and neither did she have a enlargement also. On a chest CT was done.
just by the ACHR alone is high, yeah, which is a lab report. Along with that, only with that, can we say it's myasthenia gravis? That's because respiratory paralysis.
We're
is
saying that it's associated, sir. It was associated, that's all.
It's-
Acetylcholine receptor antibody positivity is almost diagnostic of myasthenia gravis.
The titer is more
only with,
important.
it
The
copies.
titer, the titer is more important, sir. She has a very high titers. I take your point because we did a small study in the Angela Newsom Davis with Angela Vincent at Oxford. Any patients who come to the elderly clinic, we just check for the ACH receptor antibody test, whether they do have symptoms, signs, or doesn't. They do not have any symptoms or signs. They just walk into the elderly geriatric clinic, we just take the blood for ACH receptor antibody. It was found to be 0.5% positive in all those patients who are asymptomatic. Absolutely, they didn't have any symptoms at all for myasthenia or muscular weakness. So 0.5% seems to be prevalent, but their titers are very low. But here the titers are very, very high. 31 is really abnormal. So we cannot ignore that.
Sir, one question from the chat, whether there are any ocular findings, especially.
No, sir. She
no.
did not have any ocular findings.
Sir, I am Dr. Ishwarda, sir. I have few cases of Sjogren's, but none of the patient had the dry eye symptoms. They presented with the fibromyalgia. I had one patient who had rheumatoid arthritis, and she was presented with cerebral venous thrombosis. And that patient, we did ANA profile, it was a Sjogren's positive. She was on steroid, and now she's in remission. She is coming to bring her son only. She is absolutely normal. She has only symptoms of rheumatoid arthritis. I had another patient, Sjogren's, with a hyperkalemia with myasthenia. These patients, as Dr. Arul said, many of the patients we do see the Sjogren's this is positive, but very few are very symptomatic. They present with a neurological problem. But I rarely see with the dry eyes or the classical signs of Sjogren's.
We agree with you, sir. Sjogren is actually a spectrum. From asymptomatic, they can have severe symptoms also. We've had even a case with the hemorrhagic brainstem encephalitis, we gave cyclophosphamide and recovered. So it's a spectrum basically, and it can anytime go down the spectrum or travel up the spectrum.
And they do respond to steroids. So that is very interesting.
Yes, sir.
So I think.
Dr. Vijayan, it's a nice case. We also, myself and Balamurugan, we saw a case about 10 years back. She was presented with quadriparesis, found to be hyperkalemic. Then it was found to have a renal tubular acidosis. Patient was having dental caries. Then we did this antibody and lip biopsy proved to be Sjogren. So Sjogren presenting as renal tubular acidosis as the hyperkalemic paralysis. We have published also in JAPI long back.
Vijay, I would like to ask one question. Do we need to
Sir.
independently treat myasthenia separately, or do we just treat her for Sjogren's and be done with it with immunosuppressants, which will take care of myasthenia also?
Yes, sir. Since we started on rituximab, now, as we said earlier, sir, Sjogren can be anywhere in the spectrum, either low or down in the spectrum where it can be totally asymptomatic, or very high up in the spectrum where it can manifest with lot other extraglandular manifestations, including a brainstem encephalitis, which we have seen. So in this case, we thought it would be prudent to treat her aggressively with immunosuppressant medication because her ANA was also 3+, and she had polyserositis also in addition. So we thought we treat her aggressively, and so that's why we decided to give her rituximab. And she's on regular follow-up now, sir. She's doing fine. She's on tapering doses of steroids at present.
Yeah, but myasthenia is not mentioned as one of the extraglandular involvements.
No,
So-
no, sir. We are not talking about extra. We thought that it was an association since she had a rheumatoid arthritis also.
So do we need to independently treat it, or since you are on immunosuppressants, particularly rituximab,
That
you
will take care of the Jogran
it
also.
will take
That
care of
will
both,
take-
and you will continue
yeah.
only with immunosuppressants. then.
Yes, sir. We'll continue only
Without,
with it.
without anticholinesterase agents.
Yes, of
Yes.
course, we are giving her pyridostigmine. Without the pyridostigmine, we were not able to, her power did not improve completely, sir. Only after pyridostigmine, her power improved completely.
So
And
she
then,
needs treatment for
she's
both.
still on pyridostigmine, but I have reduced the dosages, sir.
Will you
Even
consider
thought of
thymectomy?
IVIG was not never thought of.
IVIG, we did not institute, sir. Once we thought that we were sure that she did not have any other features of infection and repeated procals was negative and cultures were negative, we thought we'll straight away give her rituximab to pull her out of the crisis rather than give IVIG. IVIG, again, cost was a consideration, sir. That's the reason why we did not give IVIG. As you rightly pointed out, sir, the correct way of treating it is to go give IVIG only
Or
initially.
plasma exchange.
Yes, sir, correct. These two things are the correct way of treating it. In this case, we had a lot of cost considerations initially, and hence we straight away went to rituximab rather than giving IVIG.
Will you consider thymectomy?
Thymectomy has to be done at a later stage, definitely, because she's only 29 years old. And obviously, as per guidelines, we have to go for a thymectomy as soon as her condition stabilizes. I mean, she becomes normal, absolutely. Yeah.
Sir, my suggestion is the patient is having two autoimmune diseases. Sjogren's
Sir?
and, the patient is having two autoimmune diseases, Sjogren's
Yes,
and
sir.
myasthenia. And
Yes, sir.
probably repeat acetylcholine receptor antibody levels would be useful.
Yes, sir, it might be useful.
In further progress, I mean, assessing the progress of the NMJ. I mean,
You're right, sir. Absolutely
That
right, sir.
may-
Repeat acetylcholine antibody levels. If they are coming down significantly, then we can be very sure that the myasthenia is getting better also.
Yes, sir.
Though rare, the
Sir,
case
also-
association, hello, sir.
Yes, yes, sir, right, sir, please, sir.
Sir, though rare, the association between Sjogren's and myasthenia has been reported in literature. There are few rare cases have been reported. Sir.
Yes, yes, sir, yes. Welcome,
So
sir.
there's a good lesson is whenever somebody comes with one autoimmune disease, when the symptoms are out of proportion, probably we'll have to look for other antibodies. Though rare, there are cases reported in the literature where Sjogren has been primarily associated with myasthenia, sir.
Yes.
Welcome, Dr. Chitramalam. I
Chitramalam.
wish you take part more often.
Good morning, sir. Yes, sir.
Good morning.
Shall we proceed to the next case, sir?
Yes, sir.
Well,
Thank you, sir.
Thank you for a good
Thank you,
presentation.
Dr. Anita.
Yes,
Thank you.
a very interesting case and nice presentation, an interesting experience shared by you. And thank you, Dr. Vijayan, sir.
Thank you, Dr. Vijayan. Nothing less than what we expect from you. Great. Thank
Sir.
you.
Thank you, sir. We'll go on to the next case, sir.
Yes. So next case, I think it will be presented by Dr. Anand Vijay.
Also, again, Dr. Vijayan will moderate. I think so. I'm not sure. Or Arul, I don't know who amongst the two, between the two.
Either of us, sir, both.
Okay.
the slide visible, sir?
Yes.
Sir. Yes.
He has to go on to slide share.
I am able to see that.
Sir?
I am
இல்ல
able
என்ன
to see
slide
the
share
slide.
போல.
Slide share.
Slideshow.
Slide show.
Full screen வரல இன்னும்.
Slide show.
Yes, sir. Is it okay, sir, now?
No, not it.
Press
Aravind,
F5.
Aravind, you need to go to the slideshow. Open the மேல இருக்குல்ல slideshow.
Slide show.
Go to the slideshow.
Sorry,
Slide
not the
show la
slide
தான் sir இருக்கும். We are in
அதான்
slide.
you should go to slide share, Vijayan. Not show.
Sir?
Slide share போகணும்.
Slide share.
Screen sharing.
You are sharing தான் வருது.
The screen is visible, but
Technical team, can you assist, please?
Like, it must be full screen.
Just do one thing, sir. You can stop. Yeah. So
know.
when you're sharing now, you can select your screen, full screen. Don't select PPT. No, this will not happen. When
Is
you
it clear now?
No.
Perhaps
Do one
Anita
thing.
can help.
Do one thing. So just stop share screen.
Stop.
When you're clicking on the share screen now, there is a option is coming screen. Just select your screen option and then share. Just
Go to
click on
share
the
screen.
First,
Go to
first
share
click
screen.
on the
Go
share.
to share screen.
Yeah, Anita, you are now okay.
So it's usually. Is it coming now?
Yeah,
Yes,
it's
yes.
coming.
now it's coming now.
Yeah. Elimination.
Yes, Vijay, go on.
Good morning, everyone. I am Dr. Arvind Vijay from DNB General Medicine PG. So the case discussion is about a case of a 24-year-old female from Puniyamuttur, Coimbatore with no known previous comorbids presented to the OPD with complaints of headache associated with vomiting for the past 20 days. She had fever on and off for the past 10 days. So she was in her usual state of health 20 days back. Then she developed headache with neck pain followed by nausea and vomiting. She had fever on and off for the past 10 days. There was a history of one episode of loss of consciousness is associated with of eyes 1 week back before the presentation, and she was evaluated elsewhere. CT brain done at that time showed no significant abnormality. So there was no associated history of giddiness or limb weakness. There was no history of cough, no history of weight loss, but she had a loss of appetite for the past 2 weeks. So at presentation, she was conscious, oriented to time, place, and person. She was moving all her 4 limbs. On visual field examination, it revealed a bilateral 6 cranial nerve palsy. And there was a bilateral papilledema on fundus examination. All other cranial nerve examinations were normal, and there was no motor or sensory deficits. And all her deep and reflexes were preserved. There was also no neck stiffness. So a differential diagnosis of meningitis, cerebral venous thrombosis, and idiopathic intracranial hypertension were kept, and MRI brain was done. It showed multiple tuberculomas, both caseating and non-caseating, with extensive leptomeningitis. There was severe stenosis of both transverse sinuses, and there was sutures suggestive of intracranial pressure. So this is the MRI brain. The first image showed tuberculoma lesion in midbrain, and the next image it shows transverse sinus stenosis bilaterally. So her optic nerve sheath diameter was 6.9, which is high in both the eyes, and lumbar puncture was done. Her CSF opening pressure was 560 mm of saline, and closing pressure was 120 mm of saline, which is high. And CSF analysis done showed a cell count of 150 with the cytology showing lymphocytic phagocytosis. And her CSF glucose level was 32 with corresponding glucose 115, so which is low, and the CSF protein level was 666. So her CSF TB gene expert was also positive. TB meningitis. So TB meningitis is usually presents with subacute or chronic meningitis with symptoms developing over days to weeks. So most common symptoms are headache, fever, vomiting, neck stiffness, and weight loss. With less frequent symptoms such as they can present with confusion, cranial nerve palsy, as with this case, hemiparesis and coma. The most uncommon symptoms are photophobia, paresis, and seizures. So, TB gene expert may be used as an adjunctive test for TB meningitis. Negative gene expert test does not rule out the TB meningitis. The treatment decision to start ADT should be based on the clinical features and the CSF profile of the patient. So TB meningitis is staged in classified as 3 stages. Stage 1 is mild. Those patients presented with without altered consciousness or focal neurological signs. Stage 2 includes those patients with altered consciousness who are not comatose, or those with neurological signs such as a single cranial nerve palsy, paraparesis, or hemiparesis. Stage 3 is severe comatose patient or patient presenting with multiple cranial nerve palsies, hemiplegia, or paraplegia. She had a stage 2 TB meningitis because she had a 6th cranial nerve palsy along with headache, vomiting, with fever, and positive for TB gene expert. She was started on isoniazid, rifampicin, pyrazinamide, levofloxacin, and dexamethasone. And she was discharged after 2 weeks of admission. 20 days after the previous admission, she again presented with headache and vomiting. On examinations, she was drowsy. MRI brain done at that time showed new onset ring enhancing lesions, which is seen in the right CP angle system extending into right internal artery canal. There is perineural enhancement along the bilateral 7th cranial nerve extending up to the mastoid foramen. Similarly, new onset ring enhancing lesions seen in suprasellar system encasing the optic chiasm and extending along the intracranial segments of the bilateral optic nerves. Then there is also new onset perineural enhancement seen along this bilateral 6th cranial nerve and right 5th cranial nerve. So this image shows ring enhancing lesions. Second image shows the ring enhancing lesion over optic chiasm. So this could happen. This may be due to the paradoxical response to anti-tubercular therapy, and it is a well-known entity. It usually develops after approximately 2 weeks of treatment with ATT. It is characterized by the clinical or radiological worsening of pre-existing tuberculous lesion or the development of new lesions not attributable to the normal course of the disease in a patient who initially improved with anti-tubercular therapy. Up to 10% of patients with CNS TB report the paradoxical response, and this number may be as high as 30% in patients with HIV. So this paradoxical response has been attributed to a component of immune reconstitution inflammatory syndrome or immune restoration syndrome, which results from an exuberant inflammatory response towards incubating opportunistic pathogens. So this incidence of paradoxical response is more in patients with HIV. So in this patient, she was continued on ADT and steroids in this admission, and she improved clinically and discharged after 10 days of admission. 2 weeks later, she again presented with seizures, this time with headache and vomiting. And on examination, she was irritable, not obeying, with right hemiparesis. CT brain done showed a diffuse cerebral edema and mild communicating hydrocephalus. So transcranial Doppler done showed increased mean velocity in left MCA compared to right MCA, suggestive of vasospasm due to vasculitis. So in view of vasospasm, she was started on pulse steroids and 3% NaCl, and then the pulse steroids was tapered to oral steroids. So serial monitoring of left MCA comparing to right MCA was done day by day. So initially she had a mean peak velocity of 121 in left MCA compared to right MCA, which is 72.8, which raised on the next day. It is 165. Then we started her on with pulse steroids. After the serial monitoring, her mean velocity in left MCA started coming down. It is 133 on the next day, which came down to 63.9 after the course of pulse steroids, which is almost normal when compared to right MCA, which is 52. Then we tapered her on oral steroids and we discharged her. 3 weeks later, she again presented with blurring of vision and headache. Visually evoked potential done showed slightly prolonged P100 latency in the left eye. MRI brain done at that time showed a tiny nodular enhancing lesion in bilateral cerebellar hemispheres, pons, and right caudate, which is decreasing in size with the previous, compared to previous MRI brain. There was thick ependymal enhancement noted in bilateral lateral ventricles, third ventricle, and fourth ventricle, which is suggestive of ventriculitis. So this image shows the ventriculitis. So, in view of she had blurring of vision. In view of opicochiasmatic arachnoiditis, she was given a single dose of hyaluronidase, 1,500 units intrathecally, and we started around tablet thalidomide 50 milligram BD. So thalidomide, it is a drug with immunomodulatory properties with the inhibition of TNF alpha activity, which can help in reduce the aggravation of ring enhancing lesions and tuberculomas. Then after starting her on thalidomide, and we continued her on ATT and steroids, she again had seizure 10 days later. EEG done at the time showed a background alpha with no epileptiform activity. CT cerebral angiogram, which is done at the time, showed an increase in hydrocephalus with granulomatous mediastinal and axillary nodes and cavity in bilateral lung apex. MRI brain showed new leptomeningeal enhancement. So this is the CT brain done at that time. It showed an increase in hydrocephalus. And MRI brain done showed a leptomeningeal enhancement more near the optic chiasm. So in view of worsening hydrocephalus, extraventricular drain was placed. And again, an MRI brain done after extraventricular drain, which showed new onset leptomeningeal enhancement over bilateral cerebral convexities, more marked in left post central gyrus, and mild enhancement in the cisternal portion of the bilateral optic nerve, extending into optic chiasma and pituitary stalk, which is suggestive of opticochiasmatic arachnoiditis. So this shows opticochiasmatic arachnoiditis with enhancement in around the optic chiasm. So after 1 week, extraventricular drain was removed, but after the removal, she again became drowsy. CT brain done next day, which also showed an increase in hydrocephalus. So there is increase in hydrocephalus. We done an emergency VP shunting. After the shunting, the hydrocephalus reduced. An MRI brain, which was taken, showed a decrease in ring enhancing lesion, and there was also a decrease in vasospasm in bilateral MC and ACA. And there was no new ring enhancing lesions, and the dural venous sinuses were normal after 1 month. So she was treated with isoniazid, rifampicin, pyrazinamide, and levofloxacin for the initial 3 months, and then she was continued on isoniazid, rifampicin, and pyrazinamide. Thalidomide was initially started with 50 milligram BD dose, and it was tapered to 50 milligram OD after 6 months of the initiation. So to summarize, this patient initially presented with fever, headache, and vomiting, and diagnosed to have TB meningitis with tuberculoma with elevated intracranial pressure. She was started on anti-tubercular therapy and steroids, but she had progressing ring enhancing lesions, hydrocephalus, vasospasm with the focal ischemic changes. She also had developed seizures, hemiparesis. In view of blurring of vision, worsening headache, and MRI brain imaging showed opticochiasmatic arachnoiditis, she was started on thalidomide. So this is a case of TB meningitis, which is complicated by tuberculoma, hydrocephalus, vasospasm, focal ischemic changes with optic chiasm involvement. So she is still, after 12 months of starting ATT, she is still continued on ATT with thalidomide. Repeat MRI taken at 12 months of treatment again showed a ring enhancing lesion, but it is resolving now.
So the case is basically presented for initiate discussion on the regimen for TB meningitis. 2, that she had this vasculitis and vasospasm with right hemiparesis in the left MCA, and where she was pulsed with, in spite of the steroids, she was pulsed with methylprednisolone, followed up with TCD on a daily basis till the vasospasm subsided and the velocities became almost normal and same as the other side. And 3, in spite of all these measures, she developed an opticochiasmatic arachnoiditis with visual blurring, for which she was given 1 dose of hyaluronidase intrathecally and then also started on thalidomide to initiate the discussion on thalidomide also. And 4, in spite of all this, she developed hydrocephalus, initially responded to EVD, again worsened, and then she was also shunted. These were all the features in these patients, and she was in the hospital for a period of about 2 months before she got all right, and she's now coming for regular follow-up without any deficit.
Vijayan, I have a question.
Sir.
See, it was indeed during the first admission, it was indeed brave of you to have gone on with the lumbar puncture. What was the compelling reason for you to do a lumbar puncture when it was fairly evident that she had tuberculosis infection with intracranial pressure?
A lumbar puncture, without a lumbar puncture, how do we make a diagnosis? We were able to get a positive only on lumbar puncture, sir. Only in the CSF.
No. You had multiple tuberculomata on the MRI. So what was expected from the lumbar? I mean, because she was having multiple tuberculomata, because she was having increased ICP, in that situation, what was the compelling general teaching is don't do a lumbar puncture at that time. So I want to know what was the most compelling reason for you to go ahead with the lumbar puncture.
Sir, should I add one point in this, sir? This is a definite question which has been asked since, say, some 20 to 30 years. There is papilledema, there is infection, and do you do LP or not? This is one condition where LP is a must, and LP should be done, and you have to look for AFB in the CSF. Unless otherwise, before that, before gene expert, we were looking for AFB only if it is positive, we will take it as tuberculosis meningitis. And hence, it is absolutely what he has done is right, and it should be done. But again, what are the things which I immediately thought was why he has not gone for direct VP shunting? Because within 3 to 4 days, in our period and all, we immediately send the patient to neurosurgeon. We don't go for EVD or anything like that. We have to go for direct VP shunting immediately and start for anti-tuberculosis treatment. Again, the role of, we have seen several cases of iris following steroid, and the patient developed multiple tuberculoma as the patient is on ATT. And by prolonged steroids, the iris it subsided on its own, and there was no necessity for thalidomide in any of these cases. I don't know how you got to thalidomide. And there are studies which have come. Somebody also showed that there's a study which shows that thalidomide is helpful. But thalidomide is something which is a very controversial drug that took for a lady. And we have never used thalidomide so far. And with steroids, iris definitely improved. In ATT, they have to continue. And how long you gave steroids again in these cases? Because you have stopped steroids in the middle.
After 9 months, sir, 9 months she was given steroids, and then gradually.
Can I? And then, yeah.
Can I have a word?
Why VP shunting was not
designed? Sir, initially we thought that the protein content was very high. We thought that if we had straight away done a VP shunting, it might get occluded.
No,
so we started off with an EVD, and then
only when there is a raised protein, VP shunting is done. There's EVD waiting for that the patient improve. All those things are done only for hemorrhage and all those things. I don't think it is done for infective tuberculosis meningitis.
That was the only thing that was going on in our minds, sir. We didn't want the shunt to get occluded, so we thought we'll treat her initially. Initially, we thought we'll even avoid a shunt, just do the EVD and take it off after 5 to 7 days. That's what we tried in her. It didn't work.
I don't know. The previous teaching was that this is the condition where VP shunting is the treatment.
Yes, sir. Agreed, sir. In fact, later on, we had to do the VP shunting for her. That's again.
Mr. Banu,
thalidomide, is it available?
Yes, sir. It's available very much, sir. It's available, very much available. Thalidomide, I've been using it for opticochiasmic arthritis. At least we've had 4 cases where we're using thalidomide now, and it's giving good results. Except in one case, It failed because it was too much down the line when we started thalidomide. So
What
that
was
case,
the age, what was the age of the lady? And
this lady was
29.
29 years old, sir.
I don't think thalidomide is indicated.
Sir,
Dr. Vijay?
only thing is we can, we have told her to avoid pregnancy and we have decided to stop the thalidomide. As we have weaned it off, we decided to stop the thalidomide as soon as possible. And then we've told her to avoid pregnancy for the next 2 years.
Dr. Vijayan, can I just add a few things?
Yes, madam.
First is one, this is different things. One on thalidomide. Let me start off with this. Dr. Uma Maheshwari in MMC was following up a lot of these tuberculoma patients, and some of them were multiple drug-resistant tuberculosis where we had used thalidomide. Okay, and patients had done well. That is one part of it. I was also associated with the hospital where they treat the cancers, where we have had this multiple drug resistance tuberculosis, where we have used thalidomide. It's not an easy drug to get, and all these were about 5 to 7 years ago. As of now, I was involved in the TRC with the pulmonary tuberculosis and the drugs to be used. Nowadays, they suggest that you use a higher number of drugs and start it off with a bang, maybe 5 drugs. And recently, I had a patient who had tuberculous meningitis. I'm of late seeing Gene Expert coming positive in CSF. When I spoke to them, they said start off with at least 5 drugs. Of course, INH, rifampicin, pyrazinamide, or plus or minus ethambutol if you want, then SM or levofloxacin. And sometimes now they are using linezolid more than they are using thalidomide. And adding on, this is regarding the tuberculosis. I think this paper is in an open journal only, you can access it.
You mean to say that is used as an anti-tuberculosis treatment, madam?
Yes, which one, sir? Linezolid, yes, sir. Some of our VIP patients have been.
Linezolid. Madam is talking about linezolid.
Linezolid is an accepted drug, and moxifloxacin or levofloxacin is being tried.
Yes, yes.
And I don't
thalidomide also
think,
has been used, sir.
I'm sorry, madam, I don't know whether thalidomide has become so popular like that.
No, it is not being used in the routine patients.
Not routinely, sir. Only
it
for.
It is being used. Lots of studies are there from the African continent. In ours also, we have had some studies where thalidomide has been used, and these patients we were in a research protocol along with the TRC where we added the thalidomide, and it's not an easy drug to get. You have to get it only from certain places where they treat cancer malignancies. The thalidomide is available. It's not costly, but it's not easy to get. Then coming to the third one.
You remember, madam, we were having these thiazolidinediones and paraminosalicylate acid, all those.
Yes, sir.
All those things.
Yeah. TNS is not being used. Pyrazinamide is being used.
Yeah.
But now they are suggesting even go up to 7 drugs if you think it's going to be resistant, and can give it for about 9 months. It depends on which organ is involved and whether it's a single organ or multiple organ involvement. And I really appreciate Vijayan for going through all this hardship for such a problematic patient. I had a patient.
And I'm sorry, madam. Again, the intrathecal hyaluronidase, which we have all tried all those things long time back. And those things are all removed mainly because hyaluronidase we have used even for subcutaneous infections, subcutaneous saline you give, and then you give hyaluronidase. All those things.
I have no experience with hyaluronidase intrathecal, sir.
Yeah, nobody. All those things have been removed.
Sir, this was only for one particular reason, sir. In this case, very tough case. In spite of giving high dose steroids initially.
I think Dr. Kanaka was using it, if I'm not mistaken. Dr. Vijayan sir will know. Then Dr. Vijayan, one other thing is, I had a patient who had caries spine 5 years ago, subsequently came with an altered sensorium confusion and started coning where we had to do an EVD. And then after the EVD, we were so surprised when he comes back from the theater, he is very alert and fluid is draining. And then over next 3 days, we converted it to a VP shunt. But here was any particular reason you did not convert to VP shunt immediately?
Yes, madam. Only that we wanted to, we thought we could avoid, we could do away with it, which we failed.
So
We
much
failed.
of changes in MRI, one day or the other it's going to get.
Yes, ma'am.
lost.
It was a mistake only. We should have gone ahead and proceeded to doing a VP, and I agree with you, madam. But actually, we failed and we
No, Vijay,
we
I
had
think-
to do the VP.
Then
I think maybe next time you can, for medically, for drug resistant tuberculosis or CNS tuberculosis, I think we can start off with 5 drugs. That has been a recommendation from the DRC, and they're also going through a project. Of course, they're using the newer drugs, but that is not yet into the regime. But they say that you start with intensive therapy, 5 to 7 drugs also.
You're
I can
right,
share
madam.
the paper with you later if you need it.
Yes, madam, you're right. Please share the paper, madam. But the only the WHO recommends
Our
that
ICM guidelines are there.
the WHO recommends that if there is the 4th drug, the neurologist, that's a recommendation. And regarding steroids and all the adjunctive therapy, it says leave it to the neurologist. Do not
Yeah.
interfere.
No,
Yeah,
we also
that is-
have our own tuberculosis research center, ICMR research center guidelines. I'll share
Madam,
it with you.
please
I'll
share it, madam. Please share it, madam.
Yes.
5 drugs now, can we?
Because recently I had a patient, I discussed with them.
What will be the 5th drug, madam?
Okay, see, they told me to give SM, INH, rifampicin, pyrazinamide along with levofloxacin.
Okay.
This was a case who presented like an IIH. I think Dr. VN sir also has seen that patient. She is a doctor. She presented with bilateral lateral rectus paresis and papilledema. We thought it was IIH. When we did the CSF and we sent it, the gene expert came positive. Proteins were marginally elevated. So, and there were, of course, there were lots of cells, about 1,000 lymphocytes. So when I discussed with them, they told me that you put her on 5 drugs. And she was not willing to take injection. So they said, okay, then you add ethambutol, monitor the vision. So now she is on INH, rifampicin, pyrazinamide, ethambutol, and levofloxacin.
And that is
Along with
only
steroids.
controversy is ethambutol in
Yeah, I
patients with
understand.
tuberculosis meningitis.
This
Yeah.
one did not want SM. They are also using kanamycin. Kanamycin is given by the TRC itself whenever patient needs it, if patient is not responding to the regular regimen.
Yes,
Just for
absolutely
information for people who are
right,
listening.
madam. So
The second line drugs is not available in the regular market. We can get it from the TB Research Center people. They have in all the districts, so they're willing to supply. We coordinate with them. We register our patients in their program. This is just for.
Ultimately, this is a difficult.
Can I make some comments, Bala?
Sir, 1 minute, sir. Sir.
After you.
Yes, sir. Yes, sir. A difficult case of TB, not so easy case of TB meningitis. That's what now often we are having the same dilemma. First, what Vijayan sir raised, what is the duration of treatment? The patient has been on ATT for so long. Even now we have 4 3 patients in our ward. The ring enhancing lesions are persistent, same size. Of course, in this patient it has been reduced, but the lesions are persisting. The patient is having on and off symptoms. So what is the total duration of ATT treatment in such situation?
The guideline says that you continue for 2 years, and at the end of 2 years, if the ring enhancing lesions are still persisting, stop the ATT.
Should we have to go for a biopsy, sir?
18 months to 2 years. Bala.
Yes, sir.
Even after that, it's
9
okay.
months, then is 18 months, then 2 years.
What is the role of biopsy, madam?
More than 2 years, no.
Madam, even after that, in certain cases we are seeing in the OP, the lesions are still persisting.
No role of
The
biopsy.
guideline says stop ATT after 2 years. That's what. But as you say, sir, definitely that's a dilemma. It's very difficult to stop. Yeah.
Then,
In this, we had a meeting along with, sorry, who's that, WHO chairperson. Swaminathan, Soumya Swaminathan. We had along with the neurology people in this because they also had some issues with the tuberculosis and HIV and all. At that time, they had that was the time when they had a very short treatment course of 6 months and all that. Subsequently, it is no longer followed for the 6 months. They have changed the regime. They have gone in for highly intensive therapy, and the duration to be decided by the treating physician, also depending on the organ involved.
And of
Bala,
late we
can
are
I
seeing,
make some
madam,
comments,
of late,
Bala?
of late we are seeing even starting the ATT.
Sorry, sir, sorry, sir, yes, sir. I stepped in, sorry.
Off late, I'm starting few cases routinely now. Starting the ATT immediately produces liver toxicity. We have seen in our ICU, almost every other case goes into liver toxicity with the standard regime.
Yeah.
That is making it more complicated, the treatment, and we have to stop it, modify the regime, and again restart. So all this happens during the course of the treatment. This, which we were not previously seeing, sir. Now every other case, the patient lands with immediately, starting within 1 week, the patient develops deranged liver, then we have to modify the drugs.
Or they develop severe vomiting. Bala,
This-
adding on to that is severe vomiting.
Yes, this we were not seeing previously. Now every other case we have liver complications in the last few months. So is there? I mean, there is some. The duration of treatment, everything is seeming to be prolonged for certain cases. Probably there is an immunological. Immunological association also going on with the infection. That's what my suggestion.
I accept with
So,
Bala
hello.
in that the patient will be catheterized, patient will be passing red color urine initially. After a few days, no, you start anti-tuberculosis treatment. Slowly, the red color will change it to a dark yellow color. Then you should be alert and look for liver enzymes and liver or ATT will definitely produce liver toxicity within a few days. But we have never had any liver failure because of that. We stop for a few days, continue steroids with INH and with ESM without other reformycin and other drugs. And slowly they improve. Again, you restart, nothing happens. But we have never had any liver failure patient, we are losing patients because of that. But ATT has to be continued after a few days. Once the liver recovers.
Vijayan.
Sir,
Oh, sorry. Sir, you continue, sir. Megandan. So, okay.
No, it's all right. This is a very common problem which you always face. This what he pointed out that at that time you transiently remove the ATT for a few days, continue with other drugs which are not supposed to be hepatotoxic, and then continue the treatment after once the patient recovers. But again, the patient does not the liver toxicity does not reappear. This is what we have found. Most we have, TB meningitis treatment is something which we are always, it is a challenging one. We are doing it for several years. And ICMR, as Madam pointed out, ICMR research was started in Madurai. We had a separate section in our department with our Professor KS, and there was a lady who was very popular. ICMR study was done at Madurai, and it was taken off to Chennai. And so C.N. Devanayagam was there in Chennai, and it was continued for a long time. And this is a problem. It's an ongoing study which is still going on. The management is not complete. Are we still in the right track? We do not know.
Vijayan,
Bala, can I make some comments, Bala?
Yeah, yes, sir. Yes, sir.
After
Yes, sir.
it,
Yes, sir.
I'm waiting, but doesn't matter. Ishwar has come. Please give
Sir,
Ishwar.
only a few words, sir. My professor used to say, the to be or not to be is a Shakespearean word. It's a TB or not TB. It's a Sherlock Holmes word. So to differentiate is very difficult. And Professor Kalyana Raman has written a beautiful article some 30 years ago in NSI about the paradoxical expansion of tuberculosis, even before the iris was described. So, and he said the new lesions appear, the expansion of the tuberculosis. You do a biopsy. You need not to do a total removal. Doing a biopsy, you are cutting out the blood-brain barrier is broken. Drugs will enter into the lesion and they continue the ATT, they will improve. That's what he said. And what we have done in some of these patients, as you said, intrathecal hyaluronidase, in those days, in spinal arachnoiditis, we used to give intrathecal hyaluronidase, but we used to give intrathecal steroids. So that's was working better than the hyaluronidase at that time.
in fact, we give it along with the hyaluronidase, sir. We give 50 milligram of hydrocortisone along with 1,500 unit of. It is similar to spinal arachnoiditis. This is opticochiasmic arachnoiditis.
Yes,
There also it's recommended. I got this basically from one of the meetings in Chennai where Professor Arjun Das told us
about this, what you were telling, sir. Professor Kalyan Raman used to do a biopsy and said that he breaks the blood-brain barrier to allow the drug to penetrate. And then he said he was planning to give hyaluronidase. Before that, Madam Gauri Devi had published a paper. From there only I took it. I discussed with Professor Arjun Das in that meeting, and he told me, if there are tough cases, just go ahead and try, especially arachnoiditis and opticochiasmic arachnoiditis.
But if the CSF cells are increased, we used to give streptomycin intrathecally. If protein is raised, we used to give steroids or hyaloids. That was the regime we were following those days.
Yes, sir. Because when cells are reactive, that means it's the cells are increased. It indicates that the meningitis is active. When protein is increased, it indicates that it's reactive and it's not active. So that's the reason. But Professor KS usually tells us this.
Yeah,
Thank you, sir. Thank you.
I won't like to prolong the discussion. I just have to make some, I have to reply and make some comments. In reply to Meghandan sir, it is well known that in spite of papilledema, we can go ahead with an LP. My question was not that. My question was, when you have the answer in the MRI, when there are multiple lesions of tuberculosis, what was the compelling reason at that point of time to go for a TBM, for a lumbar puncture, because we are not going to get additional information. That's okay. Anyway, with coming to the treatment, yes, in INH resistant cases, we put them on levoflox, which improves the outcome. And then if they are resistant to both INH as well as rifampicin, then probably the drugs of choice would be streptomycin, pyrazinamide, levofloxacin, eteonomide, and thalidomide. These have been mentioned in the literature. It's very well known. And most of the studies have been done in Vietnam by MRC. And two other drugs which have come of late are delanimide and bedaquiline. These also can be tried in difficult cases. Linezolid, particularly in children, has been found to be helpful. So another word about this, quinolones, both levo and moxi, have the highest penetration to the CSF. They have an 80% penetration into the brain. And this is followed by pyrazinamide and then INH. So these are the drugs which enter the CSF and enter the brain. I just wanted to make this comment, and I think we have taken enough time.
We can go to the next, sir. We can go to the next because we have
Yes,
two more
Bala.
cases, sir.
Yes, Bala.
Next, we'll invite the moderator, Dr. Arun Suran, sir. Should we go on to the next?
Yes, sir. We'll go to the next short capsule presentation.
Thank you, Mr. Vijayan, sir, for interesting two cases, and especially the challenging tuberculosis meningitis, and with so much lot of discussion. So we'll go to the next case, sir.
CNS tuberculosis always provokes discussion.
Yes, sir. Sir, interesting. I want to know what is capsule. Shall we go, sir?
Yes, sir. We are trying to share the slide.
Yes, sir. Yes.
Bala, it doesn't matter if we take a little longer. Don't worry.
Okay, sir. Okay, sir.
Are we seeing the slide, sir?
Slide show will be better. Slide show. Yeah.
Slide show.
Again, we'll have to go for slides. Full screen.
Full screen, sir.
Is it there, sir? No full screen?
No.
No, sir. No, sir.
Go back. Stop share. Share. Is it coming, sir? No?
Not yet.
Screen sharing.
Stop screen sharing. Stop screen sharing.
Stop screen sharing.
Open up with the slideshow. And then share the screen.
Is it coming, sir? No?
Yes. Yes.
Introduce yourself.
Good morning, esteemed faculties and my dear colleagues. I am Dr. Raghulan, first year GNB General Medicine resident in a Royal Care Super Specialty Hospital. And this is a case with a 17-year-old male with a myoclonus. and we are going to proceed further.
Move the slides, please. Move the slides.
This is a 17-year-old boy from Harur, Dharmaburi. He had completed class 11. He was in his usual state of health before 2 months, following which complaints of memory loss and overall cognitive decline, complaints of jerks of the body parts for the past 2 months. 2 months back, he was well, following which complaint of decline in cognition, inability to write, difficulty in reading, memory loss, forgetting names of his relatives and parents' mobile numbers, wearing clothes in a wrong way, either upside down or right to left changed, wearing footwear in a wrong foot. He was repeatedly asking questions whether he was doing things correctly or not. There is a gradual decrease in his scholastic performance, and he needed a scribe to write class 11th exam. He had behavioral changes, including rubbing his palms or face for the past few months. He noticed the repetitive jerks for the past 2 months. Initially, the jerks occurred once in 60 seconds, and then once in 30 seconds. For the past 1 month, it occurs once in 10 seconds. There is a history of posturing of his left hand while sitting and walking. Jerks increased with the walking and were present during sleep. There's antenatal history. Antenatal and birth history had no significant events. Growth and development. There is a development delay till 1 year of age, after which he did not catch up and maintain the delay. Vaccination history. Vaccination done only at birth and missed other vaccines. At 6 months of age, he was diagnosed to have vesico-ureteric reflux and underwent circumcision at 9 months. And at 12 months, he had bladder surgery, which is details were not available. He had history of fever, thrush at 2 years of age. He had recurrent fever in childhood. He had recurrent history of falls while running in childhoods. In class 3, he was distracted in class with the difficulty in paying attention and could not sit still. At that time, he was diagnosed to have ADHD and started on methylphenidate, after which he had improvement, and it was stopped. It was continued till 6 months ago and gradually tapered and stopped. In class 9, his IQ delayed by 2 years. There is no history of fever, vomiting, altered sensorium, no history of recent vaccinations. He actually missed vaccination, no history of disturbances. An examination, blood pressure 120 by rate. His heart rate is 84 per minute. Saturation is 96%. There's no paler icter cyanosis, clubbing, pededema, enlarged palpable lymph nodes. The JVP is not raised. There was dysmorphic faces, increased intercanthal distance, prominent ears, high arched palate. Cardiovascular system examination, S1, S2 heard, no murmur. Respiratory system, bilateral R entry present. Per abdomen, soft, no organomegaly. In musculoskeletal system examination, there is no restricted range of movements or contractions. In CNS, higher functions, the patient is conscious oriented. A Montreal cognitive assessment score is 6 by 30. Cranial examination were normal. Motor system examination were normal. The slow rhythmic axial myoclonic jerks, which was observed every 7 to 8 seconds. The dystonic posturing of upper limb while walking.
Can we stop there? Can we stop? Bala sir, can we go for discussion?
Can we see the jerks? Is a video available?
Yes, it's video.
Yes, sir.
Are you going to show it now or later?
Later
Yes.
it's there.
We'll show the video. We'll show the video.
Yeah.
Ravi?
Because
the
that is
video.
going to be diagnostic.
Yes. It's upside down, Raglan.
Turn sideways. And zoom it.
Play the video again, Raglan.
Ah, SSP would be the diagnosis, first diagnosis.
Okay, Raghuram, go back to the presentation again.
Okay, sir. Shall we continue, sir?
Yes, yes, you continue.
Sensory system examination was normal. Reflexes were preserved. Cerebellar function tests were normal. The gait, that is the dystonic posture of upper limbs while walking. Meningeal signs were absent in this patient. Investigations, CBC, urine routine, liver function test, renal function test, thyroid profile, calcium, phosphate, vitamin B were normal. In CSF, the total count was 10, which is mildly elevated, is more than 5, and the glucose is 64 milligram per deciliter, and the corresponding RBS is 116 milligram per deciliter. Protein is 63, which is mildly elevated. The measles, the IgM titers in serum, it is 80, and the CSF, it is 4. Both CSF and serum titers of IgM measles antibody were significant. The serum to CSF titer is 20. The MRI brain is showing a confluent periventricular deep white matter T2 hyperintensities in bilateral parietal regions and temporooccipital regions. There's a diffuse age inappropriate cerebral atrophy. There's a mild corpus callosal thinning. This is the EEG for the patient.
You don't turn sideways, pa. Can you turn it?
I don't think we can modify here, sir. Videos, I mean, you have to modify.
Okay, we'll have to turn ourselves.
Yes, sir.
Actually, it is.
I don't think we can modify.
So actually, it is it's properly oriented. It's playing for.
It's playing.
Basically, it shows the corresponding ictal discharges to the generalized high amplitude.
The periodic complexes irka role.
Irukku sir, irukku sir.
Avladhaan venum. Right.
Each periodic complexes corresponds with the myoclonic jerks.
Jerks, okay.
There is a periodic complexes consisting of bilaterally symmetrical, synchronous high voltage burst of polyphasic stereotyped delta waves, which are seen repeating at an interval of 4 to 16 seconds. And it is having one-to-one relationship with myoclonic jerks. With one myoclonic jerks, you are able to see correspondingly there is a periodic high voltage discharges in EEG. This is the video.
Now it's okay. Watch. Okay, you had already showed us.
Okay, sir. Shall we move on, sir?
Yes, please. Bala, yes.
Yes, yes, yes. Sir, diagnosis is most likely SSP, sir.
SSP.
I mean, this SSP. The history and clinical presentation with cognitive decline. Probably a background of initially itself, we had a mental abnormality. Subsequently, no vaccination, and the history is typical of an SSP is really the first diagnosis. Usually have the slow myoclonic jerks. And
Yes,
the periodicity is usually we see it in the eyelids first, sir. The slow jerks, eyelid myoclonic jerks, and then the limbs. Here, the interesting is the patient is having a truncal, axial myoclonus, and which is also, it is very slow looking at the myoclonus.
Yes,
Possibility will be an SSP only first.
Sir, as you said that he had a background cognitive decline, probably a hypoxic ischemic insult from the birth itself.
And there is a thinning of corpus callosum, so probably
Yes.
that initially a background mental abnormality due to.
Initially, we just wondered whether it could be any neurometabolic disorders, but once a EEG is done, it showed a classical of SSPs.
Arul, going back into SSP per se, when does the regression start? Mental regression, when does it start?
I think from this boy, he started at the age of 4 or 5, I think so.
Yeah, is that unusual for an SSP?
Yes, it is.
Why do you say so?
Because it's too early to develop a cognitive decline.
Yes, sir. This patient had a fever with a rash at the age of 2 years, which the history is elicitable, sir. And within that time, SSP progression is somewhat.
I beg to differ anyway.
So usually there is a period of around 8 to 9 years from the initial infection.
Yeah, usual is okay, but
This is too early, sir. This is
cases
too
even
early.
at 5 years, we do see cases even at 5 years, starting at 5 years, and then the classical features of myoclonus coming on later at 8 years, 9 years, and sometimes even visual phenomena, visual disturbance starting earlier at 6 to 7 years. Anyway,
This boy's got a background brain insult itself.
Insert, sir, that could be the
So
possibility.
probably he had a brain reserve was very little, and further insult has happened rapid progression. I think so.
background insult by history, Arul?
Yes, sir. Yes, sir. He had a cognitive decline from the
No,
beginning.
no. That is cognitive decline, but was there any birth injury? Was there any birth
Yeah,
hypoxia? Was
He
there
had
development?
he had a motor developmental delay. He had a suspicious of autism.
Okay.
He had a
ADHD,
period.
ADHD.
From the birth itself, there was a delay.
Okay, then agreed. Yes.
Yes, proceed, sir, please.
SSP, it is a rare chronic progressive
Then it
demyelinating
must be-
disorder.
Yes, sorry, then you must be having two diseases, is it?
Yes, yes.
This
He had a
one is
hypoxic-
background.
He had a hypoxic ischemic injury, like cerebral palsy.
Correct.
Not exactly cerebral palsy, but he had a hypoxic ischemic insult, and then he developed SSP.
Correct.
Megandan sir can contribute further.
I was thinking about it, sir, as you, thank you very much for this, for allowing me to think about it. Mainly because, no, we don't generally, we have to confirm that with anti-measles antibody, first of all. The main reason being that case of cerebral palsy or cerebral palsy-like syndrome, where he started deteriorating in the form of myoclonic jerks with cognitive decline and all. We have to definitely rule out any other metabolic disorder like neuronal cerebral lipofuscinosis or Laforo body disease like that. No, all these things have to be definitely considered in these types of patients, mainly because that, as he has pointed out, that deterioration also started a little earlier. So all those things we have to think in mind because two diseases, instead of thinking of two diseases, all these things, and we have to definitely confirm it with anti-measles and antibody in the CSF.
It has been confirmed, sir. Both in serum and CSF, it has been confirmed.
I'm sorry, I didn't. Then, then it is definitely SSP, but two diseases, something which is always.
That is what Ishwar Das was asking, sir.
Yeah. I still feel that there is something else. We have to think of. Anyhow, the prognosis is bad.
So whether you have done autoimmune antibodies, sir? Just
We have done that, sir.
yes, you've done that.
Arul, again, what autoimmune will we look for, Arul?
Sir, we just look for NMDA because of cognitive decline and some kind of movement disorder, sorry, ataxia and myoclonus. And then NMDA, but we've done
Again, the age, Arul?
Age is agreed, sir. Age is agreed, yeah. So we just wanted to look for any treatable disorders for this boy because he's progressively going down. It's easy to brand him as an SSP. And the purpose mainly thought us about the treatment, what we are going to do this boy. As Professor Megan.
The jerks are classical, the EEG is classical. I don't know whether we need more proof for SSP.
Agreed about the diagnosis. We just want an alternative.
A few clinical presentations which are little atypical in the form of the psychiatric manifestations come earlier than the cognitive manifestations in these cases. And slowly they deteriorate. And of course, the jerks are very classical. It can even be clinical, the typical myoclonic going backwards and then very periodically occurring. All those things are very classical, but the cerebral palsy-like syndrome and slowly deterioration starts. And when does the deterioration start like that? Now you can, if you go probe into the history further and further, they may slowly say that it started like that, and So I think even there's no harm in doing any of the biopsy, skin biopsy, like all those things can be done in these cases, because at least we have to look for, though it is very classical. Once the anti-measles antibody syndrome antibodies are positive, there's no other differential diagnosis we can think of. But we have to think of clinical picture, which is definitely atypical.
So how do you treat him, sir? Apart from the routine anti-myoclonic jerks, anticonvulsants, anything else you want to try? Immunoglobulin?
The isoprenocin can be tried, sir. But the role of isoprenocin.
Sir, I'm sorry, I didn't get you.
Isoprenocin, sir.
Yeah. We put him on isoprenocin.
Bala, have you found it ever? Have you ever found it?
Nobody,
to be helpful?
no, isoprenocin is a waste of drug. I think waste of money or something. Of course, we feel satisfied that we are giving
Something to the patient.
Arul, did you try this one, the intrathecal alpha interferon? This what textbook says.
No, I did not try, sir. I'll go and look at the books. Intrathecal alpha interferon.
Interferon. Yeah.
Interferon, correct.
No series reported, but anecdotal reports are there.
Right, sir. We'll try that.
tried in several cases.
There it is. Proceed, Raghulan.
Yes. It is a rare chronic progressive demyelinating disorder of CNS associated with the chronic, and it is a non-permissive infection of brain tissue with the measles virus. Most patients give a history of primary measles infection at an age of 2 years, which is followed by a latent period of 6 to 8 years by the onset of progressive neurological disorder. Children under 1 year of age carry a 16 times greater risk than those infected 5 years of age. Because in a study, it is shown that the virus cultivated in a culture medium exposed to antibodies in a very early state can mutate and form a non-permissive infection. It will later on lead to SSPE. So it is a structure which contains the hemagglutinin and a function protein, and inside it is having a matrix protein, the nucleoprotein. The nucleoprotein is mainly maintained in the cell in a non-permissive permissive manner, which in the later stages of life get reactivated. The clinical manifestation, SSPE begins insidiously 7 to 13 years after primary measles infection. Initially, there's a subtle change in behavior or school performance, including irritability, reduced attention span, and tremors. The initial stage 1 is maybe missed because of the severity or mildness of symptoms. The patient is usually treated like a psychiatric illness in the initial stages because the irritability, reduced attention span, and the temper outbursts. The classical features of encephalitis, the fever, headache were absent in these patients. Then second stage, the hallmark of this is massive myoclonus, coinciding with the extension of the inflammatory process site deep into the brain tissue, including basal ganglia. The involuntary movements and repetitive myoclonic jerks begin in a single muscle group, but give way to massive spasms and jerks involving both axial and appendicular skeletal muscles. The consciousness is maintained in these patients. It is not affected. In stage 3, the involuntary movements disappears and replaced with chorioathetosis, the immobility, dystonia, and lead pipe rigidity that result from destruction of the deeper tissues, deeper centers in basal ganglia. The sensorium deteriorates into dementia, stupor, and then coma in stage 3 only. Up to stage 2, his consciousness is maintained. In the 4th stage, there is a loss of critical centers that support breathing, heart rate, and blood pressure. Death soon ensues. Progression through clinical stages may follow a course characterized as acute, subacute, or chronic progressive disease. The visual symptoms include cortical blindness, chorioretinitis, optic atrophy, the papilledema, and papillitis can be seen. This is the criteria for this SSP diagnosis. The major contains 2 and minor contains 4. The 2 major criteria with the 1 minor criteria are required. If the symptoms are more atypical, the more the criteria, it's more 5 to 6 are needed. The elevated CS, cerebrospinal fluid, measles antibody, which is proved in this patient. The patient will be a typical or atypical clinical history. The patient is having a typical clinical history. There's initially the cognitive decline and then later on progress to myoclonic jerks. The minor is a typical EEG finding in this patient. This is a periodic burst of short wave complexes, and there's increased cerebrospinal fluid IgG because the virus is attacking the CNS, and the antibodies are produced mainly in this brain itself. So CSF concentration of IgG mainly will be increased. The brain biopsy can be done to prove the intranuclear inclusion bodies, and the special molecular diagnostic test to identify measles virus mutated genome can be done. The treatment includes oral isoprenosin, and the interferon alpha, which can be given intravenously, intrathecally, and now it's latest intraventricularly can be given. The IVIG, ribavirin, which is antiviral, which can be tried. The amantadine, cimetidine, the corticosteroids can also be tried. And the plasmapheresis, the last. The prognosis, it is a progressive disorder that usually occurs 1 to 3 years. Apart from classical course, the very chronic, very slow progressive form can be seen, and the very fulminant form leading to death in weeks can also be seen. And the stuttering form with the remission and relapses can also be seen in these patients. These are the variants.
Yes.
Sir, if I may add something.
Yes, please, sir.
Sir, regarding the initial diagnosis of ADHD in this patient, maybe was it an initial manifestation of SSP?
It could
This be a slow progressive stuttering form.
It could have been. It could have been an initial cognitive symptoms.
Yeah, that could have been misdiagnosed as ADHD rather than maybe it was SSP all the time.
It started by the time itself, I think so.
And the onset is still earlier, sir, in this patient. The onset of the disease is still earlier.
Yes, sir.
Very early onset and rapidly progress.
In his third standard, he was diagnosed.
Possibility is also there.
70, 11th,
When he was diagnosed with ADHD.
ADHD in the second stage.
I just want to make one comment, sir, regarding the measles outbreak in the North India recently. I don't know whether it is MP or UP.
Maharashtra and Maharashtra now, sir.
We in 1974-75 presented a paper because at that time now we were thinking measles as vilayattu ammai. We were thinking that it just comes and goes. It's not a dangerous disease. That's a term, means it's not a dangerous ammai. Like that, no, that was a common thinking among the public. And we presented in Indian pediatrics and showed that it's a dangerous disease. So you have to immunize yourself against measles. Then people started, immunization came and there was a drastic reduction of measles. But even before the introduction of vaccine, measles was eradicated in other countries. So there are several reasons to be. Once we started reducing the aggressiveness of the vaccination advice, we started getting cases of vaccination-induced SSP. So again, the controversy started and people started reducing, but measles entered into the IAP regime. So it has to be given for all children. But somehow the children, the outbreak which we had was not because they have not had measles vaccination. So this is the right time that we must also, as neurologists, should also promote measles vaccine if it has not been given in childhood. That's what I want.
Yes, sir, thank you, sir.
Can we proceed to the next case?
Yes, the next case we can.
Thank you, sir. Thank you very much.
Thank you, Raghulan. And thank you.
We go to the next case by Dr. P. Shivani.
Sharing. Can you go directly? Yeah, you go directly. So you try.
Okay.
Are we seeing the screen, sir?
Okay, not the full screen.
Screen share in the slideshow.
Stop share, go back, share. No, don't press this man. Cancel this. Press share screen. Don't go to the arrow. And now share. It comes. Go to presentation.
Still not.
Open. Open. Is it okay, sir, now?
Not yet.
Screen is not there, sir. It's like
Go back. Go back. Open full screen. Open full screen. Don't share now. That's what mistake it is. Go back. Okay, you have to share screen. Yeah. Go. Open.
No, that would be.
That one. Now open. Share.
yes, sir.
Yes.
Sir, you can proceed.
Yeah. Go. Don't touch now. She'll
So start video.
fast.
Good afternoon, sir, and good afternoon, colleagues. So, Mr. X, a 28-year-old male, initially presented with history of diarrhea and vomiting, with transient weakness of upper and lower limbs. So, during the stay in hospital, patient developed dense left hemiplegia, and CT cerebral angiogram showed acute infarct in the right insula and frontoparietal lobes. There is occlusion of M1 segment of right MCA. The patient was thrombolized with tenecteplase and mechanical thrombectomy was done.
Don't touch. Click on the screen and then try.
On examination, patient was conscious, oriented, with variation in BP in the upper limb. So blood investigation, there was elevated ESR and CRP. And creat was 1.6. ANA and anti-DS DNA were negative. NAPLA was also negative. And Doppler evaluation of the renal artery showed small left kidney with increased acceleration time. Then transcranial Doppler showed systolic acceleration noted in all cranial vessels due to stenotic extracranial vascular disease. So patient was diagnosed as to have Takayasu arthritis. In 2022, patient had complaints of headache and blurring of vision. So CV Doppler showed both carotid artery showed severe concentric wall thickening. Mid and right distal common artery showed significant stenosis. And CT angiogram of the intracranial and extracranial vessels showed mild diffuse wall thickening in the part of arch, descending and ascending aorta, and complete occlusion of left common carotid artery. Luminal narrowing of the brachiocephalic artery, occlusion of left subclavian artery, and right vertebral artery was also significantly attenuated. So this is the image of Doppler showing thickening of right common carotid artery in the mid and the distal part. So concentric wall thickening is seen. This is showing the blunt flow in the vessels of right MCA. So This is a case of Takayuki arthritis
In a male.
in a male. So it's usually common in females. Male, it's a very rare condition. The chronic large vessel vasculitis that affects aorta and its main branches in pulmonary arteries. The inflammation process results in stenosis, occlusion, dilatation, or aneurysm formation. Individuals, usually less than 50 years of age. The patient with Takayuki arthritis may present with constitutional symptoms, vascular pain, and typical features such as limb claudication, decreased or absent peripheral pulses, vascular bruit, hypertension, and reduction or discrepancies in blood pressure between arms. So TIA, stroke, and mesenteric ischemia are also other ischemic manifestations of Takayuki arthritis. The most commonly affected is aorta, followed by subclavian, common carotid, and renal arteries. So we used Ishikawa criteria was based on age of onset of signs and symptoms of TA, clinical, laboratory, and angiographic parameters, and comprised on obligatory criteria, 2 major and 9 minor criteria. So we label a patient as Takayuki if he has 2 major criteria along with the obligatories must, or 1 major criteria with 2 or more minor criteria, or 4 or more minor criteria. This is the Ishikawa criteria for diagnosis of Takayuki arthritis. The arms, unobtained blood pressure, significant blood pressure difference in both the arms, easy limb fatiguability or pain, and minor signs or symptoms is unexplained fever or high ESR more than 20 mm, or neck pain and transient ameresis or blurred vision or syncope, dyspnea or palpitation or both hypertension or aortic regurgitation. The 2 major criteria: mid-subclavian artery lesion or right mid-subclavian. Minor criteria includes high ESR, carotid artery tenderness, hypertension, aortic regurgitation or annulo-aortic ectasia, and pulmonary artery lesion, left mid common carotid lesion, distal brachiocephalic trunk lesion, descending thoracic aorta lesion, and abdominal aorta lesion. So the other criteria is modification on Ishikawa diagnostic criteria, which is suggested by Sharma. A high probability of TS considered when 2 major criteria are present, or 1 major or 2 minor criteria, or more than 5 minor criteria are present. This is the Sharma's criteria. There is either left or right mid-subclavian artery lesion, and characteristic signs and symptoms at least for duration of 1 month, and 10 minor criteria, that is ESR, carotid artery tenderness, hypertension, aortic regurgitation, pulmonary artery lesion, left mid common carotid lesion, distal brachiocephalic trunk lesion, descending thoracic aorta lesion, abdominal aorta lesion, or coronary artery lesion. So the patient was fitting into this criteria of Ishikawa and the modified Sharma. So he's a young male with Takayuki arthritis, which is a rare presentation.
Shivani, we are not audible.
She said it's a young male with Takayuki arthritis, which is a rare presentation, and also with the classical concentric thickening in the vessels, which were noted on Doppler, and the very classical intracranial TCD blood flow, which showed a blunted delayed systolic acceleration in all the vessels, in spite of the MR angio showing normal intracranial vessels. Hello.
What is the further management, sir?
He was treated with the methylprednisolone, sir.
In this patient, initially when he presented, sir, he came with a TIA, and then within few hours he developed a dense hemiplegia. Just when we were contemplating on what to do, he developed a dense hemiplegia. We thrombolized. Initially, we did not know, except that his pulse was absent in both upper limbs. BP was very high in the lower limbs. So we reduced the BP, thrombolized him, took him up for mechanical thrombectomy. He improved remarkably, and he is now without deficit. He came with severe headache. We gave him a pulse methylprednisolone and he's okay. Now we just continued him on oral methylprednisolone and also started on hydroxychloroquine sulfate. And also steroids in tapering doses. Of course, now we've started him, increase the dose of steroids again, and also started him on methotrexate weekly once.
Any comments, any suggestions, or any questions? Do you have any comments, any suggestions, or any questions, sir?
CTA was done here.
Yes, sir.
Yes, sir.
We did a CT angiogram which concurred with the Doppler findings of severe stenosis in the right distal common carotid and also concentric thickening of the very narrow lumen of both the carotids.
Yes, sir. Any other?
Vijayan, was there an occlusion of either M1 or M2 on the?
Initially, sir, the first presentation, he had an occlusion of the M1, and then he was we thrombolized him, and then we also took him up for mechanical thrombectomy, and he improved completely. The hemiplegia improved completely.
Was the stenting done for the common carotid?
No, sir, we did not do a stenting, sir. We've not done a stenting. Only medications are being. He's on steroids and he's on.
Then what about the distal ICA occlusion?
The ICA occlusion was the left ICA was totally occluded, even the first presentation, sir. The right ICA is now 70-80% occluded, 80% stenosed, right CCA. Now, otherwise, he is absolutely normal now. No power is normal. He has no deficit at all now. So we're maintaining him only on medications.
When he presented, what was the NIHS? What was the aspect? When he presented the dense hemiplegia, what was the MR or CT aspect and what was the NIHS?
I forgot the exact this one, sir. Number of NIH, definitely more than 15. And the aspects was aspects. I think it was more than 8. In fact, he had a normal CT initially.
Okay.
First presentation, he had a normal CT.
That was on during the TIA phase, Vijayan.
Yes, the first TIA.
That was during the TIA phase.
That day itself, he developed that.
I know that.
Within few hours itself, he developed the hemiplegia.
Yeah, but after the right establishment of the right hemiplegia, did we have a CT or an MRI?
Yes, sir, it was done, sir. A CT was done and his CT was normal and he was taken up for, then only thrombolized.
Now, why did you go for a bridging? Why not a direct thrombectomy?
He was well within the time window, sir. He was, when we received him, he was fully normal. And then at the moment he developed a stroke, and then we immediately took him up for thrombolysis. CT was normal, so we immediately thrombolized him.
So your protocol is bridging. Most of the patients who are eligible for thrombolysis, you thrombolyze and then take him for a thrombectomy.
Yes, sir. All patients like that only. All patients, we have to do a thrombolysis first and then only take up for thrombectomy. In fact, we do a thrombolysis even before we do a CT angiogram. The protocol for us is when we receive a patient with stroke, we are convinced that it's a clinical diagnosis of stroke and CT brain is normal and is well within the thrombolytic time window. We administer thrombolysis, we administer the tenecteplase, then only we do the CT angiogram itself. Concurrently, when the technician is arming the contrast and the saline for chasing, we on the other limb we thrombolyze the patient.
I think that's the right thing to do.
Yes, sir.
What was the BP like? Well, you said that upper limb.
So upper limb BP was not recordable. Lower limb BP was initially very high. I forgot the exact numbers, but we gave nimodipine, reduced it, and then only we went ahead.
So you used nimodipine as an anti-hypertensive, and then.
Yes, sir. For BP, we always rely on nimodipine and labetalol in the acute stages of stroke. Sir. In this, actually, the first diagnosis is not Takayasu arteritis. We were, in fact, at a loss to explain, because he being a male, we never even thought of Takayasu initially when the pulses were absent in the upper limbs, then later on only. So that we had to proceed at breakneck speed at that time because he developed a dense hemiplegia after coming to the hospital. So immediately rushed him to the CT, saw that the CT was normal and started thrombolysis.
He recovered completely.
He recovered completely, sir. He is now completely normal without any deficit.
Oh, fantastic.
How was the activity of Takayasu proved? Did you do a FDG PET?
FDG PET, sir?
Yes.
No, we are going only by the CRP and the ESR. We have not done an FDG PET in him. No, we did not do. We did a CT angiogram. We did not do an FDG PET. We did an MR angiogram, CT angiogram. We have not done a FDG PET. We go only by the
how about his
ESR
coronary
and the.
circulation?
Sir?
Is coronaries are okay?
Is
Iota's.
aorta was involved, sir. Both the this by CT angiogram. We did not do a CT coronary angiogram. We did a CT aortogram. So aorta was involved. Subclavians were involved.
So why do we need FTG bed?
Sir?
Why do we need FTG bed?
No, someone was asking.
No, for the assessing the activity of the disease.
Yeah, we can do an FDG. No, not that it cannot be done. It can be done. I don't know how it's going to add to the treatment or the diagnosis.
Chitramalam sir, how
Sir?
will it, how will it help
No,
activate the disease?
So
I agree with Dr. Chitrambalam that it can be done and it will show disease activity, but
yes, sir.
I don't know in this case whether it was necessary
Again,
or not.
FTG PET can be done on anybody. That's a different matter.
Yes, sir.
How would it indicate that's what I want to know. How do you decide?
Activity vessel wall,
vessel
vessel
wall.
wall hyperactivity is seen even in unstable plaques, just like in coronary, sir.
Yes, sir.
Even in unstable carotid plaques, you can see vessel wall activity. Even plaque activity can be detected on FDG. But in fact, it is more for plaque activity, detecting plaque activity. If the plaque is unstable, inflamed, it shows up on an FDG PET.
Yes, sir.
Simple ESR will be.
Yes, sir. I'm not telling that we should do it. I'm just telling it can be done. That's all. Somebody asked it. Chitrambalam sir asked it. That's why I am.
Activity can be monitored with ESR and CRP itself.
Yes, sir. Yes, sir. Yes, sir. Agreed, sir. We did not do an FDG PET in this patient. We did not do.
It's a very interesting patient, sir. Especially male Takayasu with stroke. So,
Again, thank you, Vijayan and Arul Selvan, for bringing interesting cases.
Thank you, sir.
Thanks for giving
A
us
lot of discussion.
It was wonderful, sir. Thanks for an
That's quite typical of Vijayan and Arul and Royal Care Hospital cases. Thank you.
so we go to the
Bala,
final thing,
Bala,
sir.
you can-
Sir, I think we'll close it, sir. We shall
Yeah,
close it,
Bala
sir.
can conclude.
Yes, sir. Sir, interesting. Thank Dr. Arul Selvan and Dr. Vijayan sir for an excellent in challenging cases and for sharing the knowledge and experiences to our august audience. Once again, I thank one and all senior colleagues and professors and members of the neurological community for taking active part in this discussion. And I thank Professor V.N. sir for giving me this opportunity to share.
Okay, thank you, Professor Bala. Thank you, Vijayan. Thank you, Arul Selvan. Thank you, presenters of the cases.
And presenters.
Thank you, Meghanand sir, Ishwar Das sir, all discussants. Thank you very much.
Thank you.
And yes, and I thank Mrs. Sun Pharma for providing the logistics and the Infotech media for doing it. Thank you all. Thank you, Chitramalam, for taking part enthusiastically.
Thanks, sir. Thank you. Thank you, one and all.
Yes, thank all of you. And Banu is not there. I should thank her also. Yeah. Jyoti, can we leave?
Yes, sir. We can close.
Okay, thank you. Thank you.
Thank you, sir.
எந்த பொண்ணா எங்க சாப்பிட வரலையா